Hello. Thank you very much for letting me talk today about intellectual and developmental disabilities and mental illness. This is going to be perhaps the shortest course one has ever done in this, because these are huge topics and involve a large percent of our population. In order to do that, I'm going to talk a little bit about what is intellectual disability, and probably most of you already know. But what's important about it is that there are different definitions across different countries, and that when we talk about this in the old days, if we go way back, we're talking about feeble-mindedness. We're talking about moronic levels of cognitive functioning. So we have moved a long way from that, and we're talking about difficulties in cognitive or intellectual function and adaptive behavior, or how you work in your world, how you interact with the world. So just having an IQ problem is not enough to say you have an intellectual disability. Just as if you only have a problem with writing with the left hand, perhaps it's not a disability because you are right-handed. So in other words, one thing alone doesn't determine what the disability is. And as you can see in this definition, it talks about a couple of very important aspects. One of that is the age or developmental period. The other one is that there are everyday social and practical skills, as well as these intellectual functions that take multiple areas of your brain to work. So it's thinking things through, reasoning. It's being able to learn new information. So that's a complex problem of taking information in, processing it, and able to pull it back out again. So it's both short-term, long-term memory. And it's also figuring out how to solve a new problem, how to deal with something unexpected. So in the next slide, we're combining this by saying how many people are affected. Because when you just think about problems in everyday living, we all have problems in everyday living, right? Just remembering what you went to the grocery store is often a struggle. So how many people are affected? It's very hard to determine. And the reason is, we're not just talking about the people who are most profoundly affected, who maybe in the old days or even currently require full-time institutional care or round-the-clock care and cannot get around in the community by themselves. We're talking about somewhere between 1% to 4% of the population. In many countries, and particularly for children, disabilities are more severe early on and are represented largely through learning difficulties. And as people get older, as the brain matures, as myelination completes, as pruning happens and more efficacy and development occurs, people gain skills. So sometimes it's just a matter of giving people enough time so that they can, if you will, grow into themselves. Not everybody. So the people we're talking about as adults in intellectual and developmental disabilities, the onset was in childhood before the age of 21. For other people, it's before the age of 18. So it depends on which culture and society you live in. But it also, if you look at the United States, we're talking about roughly 8 million people in 2014, 2013. If you live in an area where you don't have enough food, or where you're exposed to toxins, or where there's huge disparities between access to education, access to good food, access to safety versus traumatic events, you get a differential experience. If you don't have a safe environment, and I'm not talking that you have to be in a house, you could be living a nomadic culture and be safe. So it's not the external structures, it's the social bonding safety, and it's the things that the body needs to function that go to the brain and development. Those are the things that will have a major impact on whether or not the brain can develop and whether or not we can form the reciprocal social interactions that we need to have as a society. Mental illness also happens in the brain, and mental illness is also prevalent across all societies. When we're really talking about mental illness, we're not talking about the worried well. We're not talking about neuroses and just wondering whether or not we're keeping up with our neighbors. We're talking about people whose ability to have a steady mood, to think through things, is reliable and can come up every day. About 4% of the population, it's estimated around the world, are affected by serious and disabling mental illnesses, SDMI. They require services. Now, in structured Western societies, we organize them into inpatient services, outpatient services, and substance abuse, which has a huge impact in particularly our poorer areas of our states. I come from New Mexico. We have many areas that are affected deeply by, for example, in this time, methamphetamine abuse. Partly because rural areas far away are hard to monitor where people can produce methamphetamine. And it really changes your experience of reality and makes you forget what it is that you're dealing with, the challenges you're dealing with every day. The disadvantages are that the cognitive impairments, the disruption in social networks, the financial impact of substance abuse is huge. What it does to being able to raise children in a safe environment is huge. Just because you have intellectual and developmental disability does not mean you are not going to have substance abuse, does not mean you will not have depression, does not mean you will not have psychosis. These are all complicated ideas, but in general, partly because you have a brain that's developed perhaps at a slower rate or at a different rate or from a genetic risk or from lack of oxygen at birth, the rate of mental illnesses is about 2 to 3 times that in the general population. And that is both from mild symptoms to severe symptoms. You particularly have increased rates of anxiety and post-traumatic stress disorder. In a vulnerable population who depends on others for care, for support, for negotiating the environment, it is not a very safe place to be to say, no, I don't like you, or no, you're touching me in the wrong place. If I need help to take a bath or to brush my teeth, if I say no to you, then maybe you're not going to come back and help me. Maybe my teeth will fall out because you're not brushing them. Maybe I will develop rashes and sores in parts of my body because you're not touching me. On the other hand, how am I going to know if you're touching me inappropriately? What's the difference between being assisted in the shower and having sexual abuse in the shower? I mean, it's a slippery slope. And so that is why you see a higher rate of anxiety and traumatic disorders in people with DD, because they've had many decades of opportunities that by nature are not being policed. And so it's this dance between allowing the right freedoms and the right supports and providing the proper safety net and providing them the environment in which they can speak. People with disabilities can speak up when they're not safe, when their boundaries have been broached. Interestingly, if you see, here's the general rate. The rate of psychosis is not at the higher limit, it's at the lower limit. It's much closer to the worldwide, for example, population rate for schizophrenia, which is right between 0.7 to 1.1% of the population. So psychotic disorders are kind of, until you get to the extremes of depression or anxiety or traumatic disorders, psychotic disorders just happen at a sort of baseline rate. And why we ask this again and again, why does that happen in the world? Well, if you think about it, creativity happens in the world too. And psychosis is not creative, but is a distortion of reality that has to be intellectually and biochemically related to the same processes. So we probably wouldn't have creativity if we didn't have changes in mood, if we didn't have changes in thinking. And part of the risk of that is that sometimes we'll have people who get stuck in certain disordered areas of that. Next slide. I wanted to tell you in this brief overview about something we're doing in New Mexico about trying to extend the access to mental health services for people with IDD. Because I hope you get an idea that my observation and my experience leads me to say that mental illness occurs in people with intellectual and developmental disabilities, not because they have intellectual and developmental disabilities, but because it occurs in people. And this model, which we call the DDMI model, is based on being collegial to other practitioners in the state, being consultative so that we can help support them, and being collaborative. On a very concrete level, we do this by, for example, in meeting a person with DD that has a provider and a team and a nurse in another part of the state, keep my own little set of notes. But these are not the medical record. These are my little notes. These are no billing sheets filled out. The person who does the billing is the provider in that site. The people who keep the notes are the provider in that site, the team that came. I don't write the official summaries the way I do if someone comes to my clinic for a consultation when I write a report. And that's what's different. And we use two methods to do this. One of that is where we go as a team in person, and the other one is using telehealth. So we go to the next slide. What you see here is a little picture of New Mexico, which for those of you familiar with the United States know it's down in the southwest between Arizona and Texas. But also I come out of Albuquerque, and this is where the university is. But we're traveling to clinics. We first started up in Taos. And the reason I chose this map is, do you see this line of mountains that come this way and over here? In other words, I want you to get a feel that there's no way. The roads go this way and that way up to Farmington and Shiprock, which is in the Indian country. Down here to Las Cruces, over here to Silver City, where we go across this mountain pass also. So we're talking 4.5 hours to get here. We're talking 4.5 hours to get to Shiprock. We're talking 2.5 to 3.25 hours to get to Taos. We're talking 3 hours to get down to Roswell. Beautiful prairie lands. So I have seen lots of sunsets. I've seen lots of thunderstorms and clouds. It's wonderful if you love to see geology and geography. I'm going to show you a couple of slides of this too. On the next one, this just gives you a little sense. This is some examples of Chaco, our vistas that we see, the Taos Pueblo. What's important about these differences is that each of those sites, being so far away, there's this metro sense, university in the center of New Mexico. There's been a long-standing sense that people from the university come in, tell you what to do, and leave. And that's not what we've done. This clinic has been operating for over 12 years. People continue to call us up and say, we have a difficult case. Can we talk it over? In other words, we are not the state investigating them. We are not the university telling them how to do it. So that's why I think that this model has enhanced the services, because we know that many times people are their own their own sample. They're the N of 1 of a person with intellectual disabilities with complex behavioral problems, with difficult responses to medications. How do we make life better and increase their quality of life, increase their participation in the community, and decrease the anxiety of the providers and the community about doing the right thing, and open the dialogue with the client so that they're actually addressing the issues and finding. One of the things, and there went the phone. One of the things that happens is that people with disabilities care to be recognized, care to participate. They are not insensitive, unaware. They don't always show it in the way that we expect. So when we're talking about people trained in psychiatry and behavioral health, psychology, social work, counseling, they're trained that anxiety disorders present like this, and you ask people questions. Yes, anxiety disorders present this way, and when you ask, are you anxious, and people say yes, that's one thing. But if you're a person who doesn't have that vocabulary, you don't know to describe this. Your body shows it, the way you make choices, the way you get angry, sometimes communicate your sadness, the changes in your sleep or your appetite, that's how you're communicating. So what we do is train people in nonverbal mental status assessment and getting history, using collateral information. And part of the importance of our team is that it's not me. It's a person with a background in psychology, and behavioral disorders. It's a person with nursing background talking about systems issues, a person with social work and systems special training to know about what's available in the state. So we are a multidisciplinary team interacting with multidisciplinary teams supporting people with disabilities, or with families who are overwhelmed and unaware that there are these issues. So that's the importance. The other thing is, as I told you, there's some pretty amazing vistas, aren't there? So this, in case you don't know, is the Shiprock of Shiprock in the part of the eastern side of the Navajo Nation. Now, Navajo Nation doesn't just encompass the corner of New Mexico, goes across Arizona and other states. So it's its own large area. The reason I highlight that is because that's an example in which the culture of people with disabilities, while being very much not excluded by the tribe, at the same time not recognized. So families are not supported in the Navajo Nation for having a person with disability, and yet the expectation is they will care for their family members. So it's this multi-layer, different messages that are coming to people, and then they come into contact with the traditional, if you will, society, and are being criticized for not speaking, not having the right eye contact, not interacting properly. Well, proper Navajo culture does not do a lot of sustained eye contact, because that would be disrespectful and challenging to the person in authority you're meeting with. You ought to be looking away. Psychiatric literature says that a person who doesn't maintain eye contact is being evasive or hiding or depressed or anxious or avoiding. So you get a cultural problem immediately if you don't adapt your evaluation skills to the cultural context in which the person was raised. And there's a difference between traditional Navajo and those raised in more westernized or Christian-based, because there's several different types of experience. The other thing that we do is that we use telehealth. And telehealth is a secure video-based system initially tied to a particular kind of cable called a T1 line that allows the information to maintain HIPAA compliance, which is the Privacy Act for maintaining health information, so that your personal information and your clinical opinions, so I'm talking about two different yous, the provider and the client, are maintained securely, just like your medical record system. And it meets the criteria for electronic health record confidentiality. There's also new software that is secure, so that you can use more public lines, but the security on either end encrypts the information before it gets sent. And so you can work off of a camera on a laptop or an office desktop. What does that do to us? That does a lot, because we get to make, you know, I talked about the 3- and 4-hour travel, which meant in order to be there for a clinic in the morning, you're leaving the night before, or you're doing 20-hour days of driving. It cuts down your travel time. Therefore, you can make clinic appointments more frequently. And what we're trying to do with a number of our clinics is go about twice a year, and in between have 1 or 2 or 3 meetings by telehealth. And so sometimes it will be for 1 client, or it could be for 5. The last clinic I had with, in the Roswell clinic, he had 5 different people come in. So in the space of 4.5 to 5 hours, we saw 5 people together, talked about their plans, who they're working with, etc. What's interesting is that most people below the age of 45 have not even a wrinkle of suspicion about this technology. So the ones who have the difficulty are the providers, because most of them are like me, older. The other one is that the younger guys actually are really comfortable talking. Like, we're talking kids of 12 and 17 on the video, no sweat. Their parents are kind of like, oh, is this all right? Is this safe? Kids are fine. Then they meet you in person, and it's really funny the first time they meet you in person, because it's usually in the same room that the video machine they're like looking at you, and then they're looking at the screen, and they're going, oh, you're the person on the screen, weren't you? So it's a way to really extend and make the consultations really hold. But one of the things you don't want to do, and now I'm talking to the people who are the professionals and the provider of care, is you don't want to just do long distance care, especially for mental health, without having some kind of clinician or safety net person on the other side. Because when you're talking with people, especially those you don't know what the risk for self-injurious behavior is, for misinterpretation or not remembering. So one of the safety things that we do, and assuring people's well-being, is that there are professionals on the other end. Usually I'm talking to another provider or clinician, but also there's a team member or something, so the individual client is not by themselves. And that's important in terms of maintaining standards of ethical care. Just like if I had a person in the office and I think that they're suicidal, I don't just say, oh, time's up, ciao, see you in a week. You don't leave people hanging with things that they've talked about that are difficult. And you can't, truly, you don't mask over difficulties. And one of the problems in our society as a whole is that the stigmas of mental illness and intellectual disability compound one on the other to suppress expressing those difficulties or challenges and not being able to access things to make them less of a barrier. But by suppressing things, they become more of a barrier, because then everybody's trying to work around it and not talk about it. So it kind of inflates, if you will. So the challenge is, the more we make it accessible to everybody to talk about and experience, it's not to suggest everybody has disability. It's not to make it a big deal. It's not to make it a headline. It's something that can be coped with. You know, a lot of my patients struggle with the idea of taking medication. And here's another analogy. Probably everybody listening to this and in this room are wearing shoes. And we've all been trained, not only that's the appropriate way to dress, but also we find it functional. We find that when we wear shoes, we support our arches. We tend not to step on stones or glass or and therefore cut our feet. We tend to not get as cold in the snow or the ice, and we tend not to burn them on hot surfaces. We think that's just normal. It's support. Medication is only as good as the support it provides. So you wear your shoes and you take them off at times. You take your medication in order to allow you to function, not in order to stop being somebody. And so the whole idea of both our DDMI clinic, about medications and about proper diagnosis of mental illness in the setting of IDD, is to support people's functioning so that the problems of mental illness, like in depression, difficulties in concentration, changes in sleep pattern, sadness, interrupted thoughts, fluctuation of mood, inability to have initiative, those things don't compound difficulties that you have in functioning because of an intellectual disability that is not improved by a pill. These are reversible, or things that can be made better or ameliorated, but not gone away, not they disappear. The last thing I did want to say is that in all assessments, we should think in at least 3 dimensions. It's something that I remember saying to our son when he was little and would impulsively run places, and I'd say, think, you're in 3 dimensions. The table is still there, you're going to hit it. Give yourself room. Well, we also have to think in terms of time, which is a 4th dimension. And for many people, spiritual dimensions, or sort of the meaning of existential dimensions, the meaning of life. So we use our senses, our brains, to respond to the world around us. And when we have disorders in that perceptual system and in that productive system, it will show up in different kinds of behaviors. And our job as professionals is to try to assess that, understand that, and make it better, and to improve people's functioning to the best level possible. So, next slide. I want to say thank you for your attention, and keep a long view and keep yourselves refreshed.